Hello, I'm Mutambirwa. I'm a urologist. I'm head of urology at Dr. George Mukari Academic Hospital and Sefako Makato Health Sciences University in Pretoria. And it's an absolute pleasure for me today to discuss a little bit about sexual health. And I know some of you might know that a lot of my research and my talks are about male sexual health. But I think today I'm going to spend a little bit of time on the assessment and management of sexual problems, both for men and for women, but with a focus on the female for a number of reasons, particularly because female sexuality has been underreported and under-recognized, but also because I think there's such an interrelation between the aspects of male sexual health as well as female sexual health. Men and women are different. Men are from Mars, women are from Venus. That's the theory. But the reality is that we all individually have our own perceptions of what our sexuality is like. Some have better, some have less. But the whole point is that it's your perception and bother. That's the most important thing. And I think when we're talking to our patients, we have to remember that it's about bother. If something's bothering them, for example, premature ejaculation, which we used to talk about, being within either before penetration or within 30 seconds of penetration. The DSM-5 has now changed that to the perception for the patient themselves. So even if a patient is doing 15 minutes or whatever, because remember the average guy ejaculates within 3.5 and 5 minutes of penetration. Generally, that's US data, of course, not African data. We're much better than that. But the point is, it's about bother. So let's keep our patients' general health and health quality at the forefront of our decision making. Because we've also got issues about the media. The uprise of the internet has caused so many good things, but it's also caused a lot of confusion and trouble for patients as well as for ourselves. And things such as the 50 Shades of Grey, implying that guys should be doing specific things, women should be doing specific things, have sort of muddied the water a little bit. And I think we need to get back to basics when we're looking at sexuality. For both men and women, it's based on a bio, psycho, social, cultural model. So it's about the biology. Do we have diabetes? Do we have hypertension? Men and women, both. Is it a psychological thing? 90% of sexuality, people say, is in the mind, the way you think about it. How are you interacting? What are you doing? The social, are you interacting with a specific group of people? Do you have a specific social group? So important. But culture, also remember culture. Culture is such a big thing. I like the example of the fact that 70% of females in East Africa only get orgasm when if they're in a heterosexual relationship, when the male partner is hitting her clitoris with his penis, not hard, obviously, it should be pleasurable. That's not the same in every country. So remember to base it on which culture, where you are, and even within diverse cultural areas like South Africa, each group, each person is individual. We need to make sure that we address them specifically. I always like going back to this, the biological. The big five is still there. Good diet, not how much you eat, not the type of diet, but what you eat, how many calories you're taking in, bit of exercise, not smoking, no stress, biggest issue, especially with COVID now, 70% of people report some form of psychological distress, not taking too many other drugs, such as alcohol or whatever. Because if you can address those, you're going to be getting rid of the underlying cause for the majority of deaths, first of all, in the world, which are cardiovascular and cancer, both of which are related to the metabolic syndrome, which is about visceral fat, which can only be addressed by exercise, diet, low stress, not smoking, and making sure you don't excessively intake and various things. It's so important to address that, because both for male and for female sexuality, because it impacts both. But today, because I think it's so important to talk about female sexual health, we can see why I think it. And when you consider that most women's problems are actually caused by men. Menopause, menstrual pain, mental illness. They have to go and see the gynecologist, and then we have to get their womb out, hysterectomy. Let's address a little bit about female sexuality, how it impacts on them, and how it also impacts on male partners as well as female partners if they're in a non-heterosexual relationship. Guys are pretty much up and down. Erection goes up, goes down. We want to have penetration. We want to have orgasm. That's it. Females, a little bit more complex. Orgasm is not always compulsory. Only 20% of females actually have orgasm from penetration alone. And even if they do have orgasm from penetration alone, it takes between 21 and 25 minutes for them to get orgasm. Guys, 3.5 to 5. Dichotomy. Foreplay for guys. Talk between partners. Make it easier. The complexity can be balanced. It's also less studied and understood than male sexuality. The biggest change for men's sexuality was actually in 1996 with the introduction of Viagra, because when those guys did refuse to bring the tablet back after the end of the trial, which didn't show a decrease in blood pressure statistically, they said, no, it's giving me a good erections. And then we started saying, oh, okay, let's investigate these guys more and say, we've had data. We now know things more about male sexuality. Females were left behind because they didn't have their female Viagra, but that's also because they're more complex. They've got more issues. It's not about issues that are a problem. It's just that they've got more complex interactions when it comes to their partner and to themselves. And on top of that, there are many theories and beliefs that are inaccurate or outdated about females. Internet, again, can bring up so much nonsense that's probably not necessary for the vast majority of females and needs to be addressed and debunked. And it's also sometimes quite difficult to address some of the problems. It can be personal issues, the lack of training from this healthcare provider, the lack of time when we're involving with patients. It's more complex, but it's not that difficult to deal with. Because if you look at DSM-4, Diagnostic and Statistical Manual of Psychiatry, and again, always get a bit surprised that the psychiatry is where both male and female sexuality is attached. It is important, but that brings us back to the fact about the way the mind thinks. 90% sexuality is in the brain, but there's a lot of other interactive things, the biopsychosocial cultural aspects. But to make it simple, as healthcare providers, so you don't think that you're going to be overwhelmed by the discussions of female sexuality, there are initially only really 3 sexual problems: desire disorders, the brain, arousal, the vagina and the clitoris engorgement, and then the pain disorders. Remember that all of these have some underlying other subgroups: hyperactive sexual desire, sexual aversion for desire disorders, for example, orgasmic disorders when it comes to arousal. But pain and dyspareunia is pain on penetration. Menial vaginismus is when you can't even enter because there's so much spasm down there. As a guy, if you're having heterosexual sex. But there's more to this than just the DSM-4. But again, to make it simple, sexual response: desire, the brain; excitatory, dopamine; inhibitory, serotonin. Serotonin reuptake inhibitors decrease desire for females, but they also are used as off-label as first-line treatments for men with premature ejaculation. 80% of guys have premature ejaculation at some stage in their life. The vast majority will respond well to SSRIs or SNRIs. When it comes to arousal, vaginal engorgement or the clitoral, it's oxytocin, vasoinhibitory protein, nitric oxide. Nitric oxide, isn't that the same one that's targeted by PDE5s? Yes, indeed. Super important. The vagina and the bladder and the clitoris have lots of PD reflectors. Nitric oxide is super important for vasodilatation, relaxation, letting blood run into there. Inhibitory, noradrenaline. It's a no-brainer. It causes constriction, but it is important after climax to decrease, for example, in men, priapism, to stop you from having an erection, which is not going to be, it was going to last overly long. Orgasm, noradrenaline, acetylcholine are excitatory. Wow, surprising that both the ones that usually are inhibitory to each other in the periphery, are now both necessary for orgasmic function. And serotonin, again, is inhibitory for orgasm, which is a good thing for premature ejaculation patients, but it's not for women who are looking to have orgasm at some stage. And sexual difficulty is actually more prevalent in females than it is in men, if you look at most of the data. It's huge numbers of females who are having a problem, even compared to their male counterparts or partners. And although a lot of patients will say, oh no, it's not really an important thing, I don't need to have sex, it's fine, my partner is getting older, diabetic, back, comorbidities, there are so many benefits from having sex. Relieve stress, oxytocin, various other things, exercise, boosts immunity, burns calories. Sex is a form of exercise. If you have 15 minutes of sex twice a week, you can burn off the equivalent of a Big Mac meal every week with Coke. Coke, not full. Okay, huge. It's an important aspect. So therefore, it will also improve cardiovascular health. It also improves our self-esteem, not the brain. So important. Improves intimacy, interaction between partners. Because remember, masturbation is also a form of sex. Very good for your health as well. It does most of these things that we're writing here. But the only difference between masturbation and intimate sex is the intimacy. Intimacy gives some added benefits. But of course, if you don't want to have penetrative sex or whatever, or intimate sex with a partner and you just want to do it yourself, perfectly reasonable. Still good for your health. Still good for your health. It reduces pain. For guys, it reduces prostate cancer risk. Very good data. That shows that if a guy is ejaculating at least 7 times per month from whatever thing, it decreases the risk of prostate cancer. We're emptying some of the prostate juices, which are 30% of what a guy ejaculates, helps to decrease the risk. It strengthens the pelvic floor muscles, and it helps you to sleep better. Melatonin is being released when you're having sex and orgasm. Good stuff. Sex is good. But when it comes to female sexuality, there have been many myths. And these I'm just mentioning them so I can debunk them, that these are not true. They're not true. Organic dysfunction can be meaningfully separated from psychological dysfunction. No, they're interrelated. Awareness of internal feelings of sexual desire is a primary trigger for sexual behavior. Females can be stimulated within seconds as well, depending on what they feel. It doesn't have to take a lot of internal feelings. There can be massive differences in the way they feel sexual. Sexual desire necessarily precedes sexual arousal. Not true. They can have sexual arousal even if they have no desire. Women arousal identified primarily by genital vasocongestion. No, there can also be relaxation in the areas. Lots of things. There's always vaginal lubrication. No, no, no. Vaginal lubrication, you often, even when a woman is fully aroused, you still need some lubricant. It's not her fault if there's something going on there. There's other issues that each person is different. Awareness of genital sensations is a primary aspect. No, most women, intimacy is paramount in the majority of their sexual actions. And remember, that's why for guys who are watching, or you're going to talk to your patients, foreplay, foreplay, foreplay. It's so important. Touching, licking, doing even a flower a month ago is part of foreplay. Women's sexual response is essentially stable and invariant across the time and circumstance. Nonsense. As women change, be it from pregnancy or from aging or whatever, things change. And we'll touch a little bit on that just now. All women experience distress about alterations and limitations in sexual response. Nonsense. Women can be very comfortable being fully celibate or changing the way they interact sexually. So if we look at the biology, penis is mainly made up of 2 spongy tissues, one on each side, there's corpora, and it's where most of our focus when it comes to erections goes. A bit of increased blood flow to the penis gives us an erection and we feel like using it. Females, slightly different, but almost the same. 3 G-spots in females. One is the clitoris, which is exactly the same length as the penis. MRI data, we've done trials which shown on MRI, functional MRI, same length, you notice thick. Anterior wall of the vagina and the bottom part of the cervix. So important that there's so many aspects of sexuality which are related both to men and to women. But the vagina and the clitoris are like twins. If you are stimulating the clitoris, the vagina will get more aroused as well. And similarly, when the vaginal is aroused, the clitoris gets more aroused. The labia are more ectodermal organs, so they have more testosterone and stuff. And testosterone is important for sexuality, as we'll touch on a little bit later. And although we've based most of our sexual function on Masters and Johnson in the past, and it's a very good structure where if you look at the black line, that's the guy, he's getting excited quickly, he gets orgasm, and he goes down to nothing, resolution immediately. Only people who can have multiple orgasms are females. Guys are going to say, oh, no, I've managed to not pull out and I still have I've had multiple orgasms. 8 best erections for guys, 18 to 22. After that, we all start to deteriorate a bit. The biggest issue is about the refractory period, the period where you can get an erection and get another erection, which if you get to 80 will be a 30 days cycle. That's how long. When you're in the 18 to 22s, it can be up to less than 5 seconds, but it's still just a refractory resolution period. Females, on the other hand, if you look at the red line particularly, you can gets to the plateau, orgasm, then resolution. Slightly different for both men and women, and it's a useful model. But we now know that it's a little bit more complicated. Again, it's not just about getting to the orgasm or getting to the plateau. It's about emotional intimacy, sexual stimuli. There are biological aspects with impact on the sexual stimuli which lead to arousal, the sexual drive, arousal and sexual desire. Far more complicated, we think now, but still relatively easy to manage for the vast majority of our patients. But it's important to remember, particularly when we're talking to female patients, although male patients have exactly the same problems, probably just in the lesser numbers we've seen on the data, sexual function is important, but that's based on the experiences that they've had in the past. Have they had a rape episode? Have they had a premature ejaculation in the past? It has to be addressed. It's a complex, multidisciplinary subject that needs to be addressed. Fertility can be the main aspect for sexuality. And when people are having infertility, 15% of patients out there, it impacts on their sexuality. Now they're thinking, oh no, we have to have sex every day, or we have to have it 5 times a day. It's no longer pleasurable. It's a big aspect. We have to address that, make sure everything's comfortable. Everything's about relaxation. The satisfaction. Are you satisfied with what you've done or with what your partner is experiencing? And I think we have to make sure if you do have in a partnership, our patients must be able to have a discussion about what they want, what they don't want, how they want to improve or decrease the amount of sexuality. How important is the sex? Might not be that important for that person at that time, needs to be addressed. And I guess this is more esoteric, but what's the meaning? What's the meaning of sex for them? For each person, a cultural or social or religious or whatever background can impact on sexual functioning. But age is not the end of sexual interest, both for males and for females. Data from France, we showed that if a guy over the age of 60 has sex twice a week rather than twice a month, it increases the longevity by 6 years, regardless of any comorbidity. 6 years, just by that, regardless of comorbidities. For women, females, it was 8 years. We have to be open. Let our patients understand that this is actually good for their health. Sex is good for your health. But for females, menopause does have a lot of effects. Decreased sexual activity, dysfunctional male partner, erectile dysfunction. I'll show you some data just now that how that impacts on females. Vaginal dryness and pain when intercourse. Diminished response, decreased desire, because female and male sexual desire and part of the arousal is based on various hormones, but particularly testosterone. Testosterone is the key for male sexuality, feelings, libido, but it's also the same for females. Estrogens is not as important for the sexual functioning. And now we're doing a lot of trials looking at supplementing females as well as males now for various sexual dysfunctions. But even estradiol goes down when it's important. That's for bone strength, both for men and for women, because men also have estradiol, by the way, estradiol, It's from conversion from testosterone and the by aromatizing the peripheral fat. And androstenedione also goes down both from surgical and natural menopause. DHEA also plummets as well, and that's the so-called happy hormone. All of these need to be addressed, and going forward, we're going to get more research about supplementation for females. In addition, the vast majority of older patients particularly are on up to between 5 and 10 different medications, and all of these can have impact on their sexuality. For example, desire disorders, and this is not an exclusive list, but psychoactive medications such as SSRIs and such, hormonal agents can suppress it, cardiovascular medications, be it beta blockers or whatever, and many others can cause problems with the feeling of having sex. Engorgement can be influenced by anticholinergics. We know that anticholinergics cause a problem like, for example, constipation that has the same issue in the vagina, can cause a lot of issues there. Antihistamines can do it. Antihypertensives again, and other psychoactive medications can impact on the engorgement of the vagina, clitoris. And by the way, all of these are also the same for men. Orgasmic, amphetamines and anorexic drugs, antipsychotics, methyl-dopa, narcotics, SSRIs again, trazodone, tricyclics, a lot of medications we use almost every day are causing problems for desire, arousal, and orgasm, and even pain. So, we as clinicians, what can we do? First of all, we're in a bit of a conundrum, because we also have our own issues and our own sexuality. And I'll just express that if you don't have, it's important for us to discuss with our patients, but if you don't feel comfortable because of any of these things, be it personal issues, lack of training, lack of skills, lack of time, fear of embarrassing the patient, lack of treatments, which they are there, and beliefs in sexual interest, the belief that sexual interest declines with age, at least send it to somebody who has an interest in sexuality. We're all humans, we all have our own decisions and where we want to go with our lives. But all of these things impact on how we interact with our patients, and we must look in ourselves to find out which of these are impacting on why we're not discussing sexuality, both with men as well with women. If you decide you're comfortable, use the implicit model. Get permission. Can we talk about sex? Give limited information initially to say what's going on. If you can pick up a specific cause, you give specific suggestions. And if that doesn't work, you can go on to intensive therapies, which there are many of. But I'd just caution that we must avoid biases. Age, we've already discussed, it shouldn't be a bias to sexuality. Sexuality is good at any age. Orientation, that's a big issue. There's so many people who are out there with different sexual orientations. We mustn't be judging them. If you do have a problem, again, rather refer to somebody who's comfortable dealing with that. Relationship status, it changes, it varies. Some people are in threesomes, some people are in, there are many issues. Try not to be judgmental. There are only two sexual problems that I like to tell my residents that there are. Both of them are probably the same. One is taking somebody by force. Any form of rape or lack of consent, unacceptable for various reasons, as we know. Second is taking a child. It's the same thing. But in the consenting relationships, what's your problem? Let them get on with it. If it makes them happy, they're improving their health, they're all consenting to whatever they're doing, please let it go. Cultural issues are also a big issue. Has to be addressed. If you're not culturally comfortable with their culture, send to somebody who is. And although it's quite easy to find products for men for their treatment, which is the biggest, is erectile dysfunction for the vast majority. Although remember, premature ejaculation is a huge issue, and also decreased libido, mainly based on testosterone. For females, it's a little bit more complex, but we still can handle it quite well. First of all, when you're treating desire disorders, evaluate the relationship and personal issues, or else send to your psychologist or romance therapist. Treat underlying medical conditions, the diabetes things, all of these things can cause problems. Change the medications if necessary. Hypertension, beta blockers might be an issue, you can change it. Prescribe estrogen and or testosterone, although testosterone is still off-label, usually vaginally that we'd like to do. But if you can't do these things, counsel and at least refer patient, and try to include the partner. Arousal disorders, vaginal engorgement, clitoral engorgement. Avoid boring routine sex. Vary it, might help. More focus to direct stimulation, for example, vibrators. Lubricants, and moisturizers. Excellent. Even the majority of 80% of women still have a bit of vaginal dryness, even if they're fully aroused. Lubricants. You can also use, by the way, if you can't buy the over-the-counter stuff, egg white works very well as a lubricant, even if you're trying to have a baby, because it's not like gel-based, which can damage sperm. Regular penetration. The average married couple in America has sex 2.3 times per month. That's probably contributing to a lot of things, but it's also the basis of a lot of the problems. When people have got diabetes, hypertension, they're not generally healthy, they will have less sex, and that leads to less penetration, which leads to less sexual satisfaction. And of course, there are hormonal things like vaginal estrogens. Remember to be careful if your patient has had breast cancer, they shouldn't be doing that. And we have data now to show that testosterone works almost as well for estrogens in patients with vaginal arousal disorders, because it has no impact on the breast cancer. Orgasm. If they're on SSRIs, consider getting them off it, because it can impact on their orgasm. Treat the pain. We've already said dyspareunia, be it from lubrication or pelvic floor spasm. Do what's necessary. Explain orgasms may be situational. It don't always happen. Sometimes it might only happen when you're in a specific position or when a position plays. It's important. Counsel and refer to sex or and relationship therapies, but importantly, educate about sexuality and arousal in these patients. Pain can be quite complicated, but again, here comes lubricants. Lubricants can be very helpful for a large number of patients with sexual pain disorders. Treat medical conditions, education, vaginal dilators, regular penetration again. Vaginal or oral estrogens can be used for sexual pain as well, but the basis is that we have to identify what the problem is for our patients. But remember that the partner is also extremely important. We know that if the female partner has a problem, quite very often the male partner also has a problem, be it from erectile dysfunction or whatever else is going on. We need to address that to make sure that our patients are very comfortable with their own sexuality, but bring their partner, if they're in a sexual relationship, for them to be addressed. And I think to end off, this slide is from my big buddy and friend, who also supplied a number of the slides that I've used today. You're probably wondering why a guy is talking about female sexuality, but it's because of my training from my mentors. As they say, you're only as big as the giant that you stand on the shoulders of. Elna McIntosh supplied a number of these slides, but she said that this thing, strong women wear pain like stilettos, no matter how much shirts, all you see is the beauty of it. That is important, but it's also important to change that. It doesn't have to be pain to be happiness. And with that, I'd like to thank you for your attention and enjoy the rest of your day.